So basically, AML is a very heterogeneous hematological malignancy, which includes multiple genetically defined subsets. And the main genetic aberrations included in the European Leukemia Net 2022 classification are NPM1, FLT3, CABP alpha, which are within the favorable and intermediate risk groups, but also multiple mutations that are classified in the adverse risk group, including RUNX1, ASXL1, BCOR, EZH2, SF3B1, SRSF2, STAC2, U2, AF1, and TP53 mutation. And in the context of allogeneic stem cell transplant, the frequency and prognostic value of different gene interactions has not been studied and may differ from that of patients treated with chemotherapy alone. So the aim of our study was to evaluate through the European Society for Blood and Marrow Transplantation database the frequency and impact of different recurrent somatic mutations, either alone or in association, on prediction of relapse and survival in patients receiving allotransplant. So inclusion criteria were adult patients more than 18 years with diagnosis of AML, first allotransplant between 2013 and 2022, and available genetic profile by next generation sequencing. So overall, we identified 836 allografted AML patients with pre-transplant NGS. 88% had de novo AML, and median age was 53 years. When we look to the frequency of mutation, the most frequent mutation in the transplant setting was the NPM1 encountered in 33% of patients, followed by FLT3-ITD and NPM1 in 29%. Then we have TET2, NRAS, RUNX1, WT1 between 20 and 30, BCOR, ASXL1, IDH1, IDH2, SRSF2, STAC2, CABP alpha between 11 and 20, and TP53, KRAS, and PTP and 11 at 10%. So we then performed a multiple correspondence analysis on patients who were tested simultaneously for the most frequent mutation. So a group of 335 patients and two independent groups of co-occurring mutations were identified. The group one included mutations of the NPM3A, NPM1, and FLT3, and the group two included ASXL1, SRSF2, and RUNX1 mutation. So we then moved to outcome analysis. And in this case, we focused on patients, allografted in first complete remission with available data for these 6 mutations, ASXL1, RUNX1, SRSF2, NPM1, FLT3, and the NPM3A. So overall, 298 patients identified. So when we look to the outcome analysis for the 6 mutations as single mutation, only NPM1 and FLT3 ITD positively affected overall survival without affecting leukemia-free survival, whereas the other 4 mutations had no impact as single mutation. But when looking to the mutations as group of mutation, we noticed the best outcome for patients with NPM1 mutation, regardless of the other mutations, with a 2-year leukemia-free survival of 70%, as well as for patients with ASXL1, RUNX1, or SRSF2 with wild-type NPM1, FLT3, and the NPM3, And for these patients, 70% LFS also. The worst outcome was noticed for patients with FLT3 and or the NPM1 in the absence of NPM1 mutation, with 2-year LFS of 56%, as well as for patients with all 6 mutations negative with a 2-year LFS of 56%. So in conclusion of our study, the NGS and diagnosis can be extremely useful in risk stratification of AML patients undergoing allotransplant, potentially allowing adequate post-transplant interventions. 2 independent groups of co-occurring mutations were identified. Group 1, the NPM3A, NPM1 and FLT3, and Group 2, ASXL1, SRSF2, and RUNX1. And when mutations were investigated in groups, the 2-year outcomes were the highest with NPM1 mutation, regardless of other co-mutation, 2-year LFS 70%, as well as for RUNX1 and or ASXL1 and or SRSF2, 2-year LFS 70%. And I remind you that these were classified as adverse risk in the ELN 2022, which means that the transplant is totally changing their impact. And the worst outcome was with all 6 mutations unmutated, 2-year LFS 56%. Thank you for your attention.